Let's go. Hi, I'm Tammy Freeberg from The Village, a multi-service organization and one of Connecticut's largest community mental health providers. Today, I'll share how we tried to build an integrated care partnership for kids and some of the ways we failed before we made it work. Pediatricians' offices are overflowing with behavioral health concerns, and physicians are struggling to respond to the crisis. Despite this, behavioral health integration has not been widely adopted due to limited viable models. The Village built a partnership with Connecticut Children's growing clinically integrated network, or CIN, to advance whole child care. Our objective was to embed Village behavioral health clinicians into pediatric primary care practices across the state. Why? You know, to increase access to behavioral health care, intervene earlier, and support families more effectively. We wanted to strengthen team-based care, improve outcomes, and align with healthcare reform, particularly around primary care. First, we tried joining the CIN so that the Village could be included in collaborative quality and contracting arrangements. We negotiated and executed a participation agreement to achieve this. But insurance companies rejected this idea. It didn't fit their model. Behavioral health was often a carve-out, and they didn't view Connecticut Children's CIN as a behavioral health network. We couldn't get the contracts, so we had to pivot. Then we tried contracting directly with the practices in what we called the net stipend model. The practices would pay the Village a flat fee to co-locate a clinician, and we'd return all net collections achieved through billing. Our attorneys shut this down. There were concerns about anti-kickback laws and antitrust exposure. Physicians would be referring to services where they had a financial interest. It seemed simple, but it was legally unworkable. Then we tried something else. The practice would lease the clinician from the Village, add the behavioral health provider and codes to their contracts, and bill for the services rendered, essentially internalizing the role. This didn't fly with pediatricians. They struggled to get health insurance companies to impanel and contract for a single clinician. But the real fatal flaw, actually, was that the practices did not want to assume all of the financial risk for what to them was a new and unfamiliar service line. Our fourth try was a different staff lease model. Connecticut Children's would lease the clinicians from the Village and deploy them to the practices using a session or other space lease, assuming all responsibility for contracting and billing. It was closer, but neither partner was comfortable with this approach. It felt more like outsourcing than partnership. With limited mutual value and easy substitutability, there was no stickiness. We were worried it wouldn't last. We decided to reset. Instead of forcing structure first, we got clear about what success would look like, clinically, operationally, legally, and asked our attorneys to help figure it out. This took time and money, but it was worth it. We ultimately formed a clinical affiliation akin to a joint venture, but without a separate legal entity. It baked in joint planning, shared risk, and alignment on quality. We had to overcome some big challenges. One was the power differential. We're a community-based organization. They're a health system. We had to know our value, build and maintain the relationship, and establish accountability mechanisms like timelines and check-ins. What we were trying to do was inherently complex, from liability to privacy to the interests of other stakeholders like the payers and the practices. We had to engage legal counsel with the necessary expertise to navigate these challenges. One key to success was a third-party valuation of each party's contribution. It helped us meet legal and regulatory requirements and made negotiations easier. It gave both parties a shared language based on data, not assumptions. This wouldn't have happened without executive champions. Both sides had senior leaders who shared a vision and kept it alive, clearing roadblocks, making decisions, and modeling that this was a strategic priority. And now it's happening. 2 practices launched this spring, and a third is preparing to go live. Children and families are receiving behavioral health care in the trusted and convenient environment of their pediatrician's office. Along the way, we learned a few things that might be helpful if you're trying to build something similar. The first is engage your lawyers early and keep them involved in the process. Second, build and maintain those relationships with your prospective partners. And lastly, don't give up. Thank you.